I would like to thank the foundation for inviting me today to talk about a topic about our work and a topic that we've been dealing with for several years. And I want to thank the audience who have been very resilient to sticking it out or staying until the end of a long day here. So the goal today is to cover some of the work that we are doing with regard to novel treatment for individuals with autism. First, there is no conflict of interest relevant to this presentation. And I will divide this presentation into two groups. One is oxytocin and arginine vasopressin systems. We'll talk about the oxytocin biology and trials that we've conducted, but also we'll talk about arginine vasopressin, its biology, and the trial that we are currently conducting. And in the second part, we'll talk about glutamatergic modulators with N-acetylcysteine, which is a glutamatergic modulator, but also an antioxidant, and pregnenolone, which is a neurosteroid. First thing first, with regard to oxytocin. So, as you all know, oxytocin is best known to be released after the distension of the cervix and vagina during labor and after stimulation of the nipple, facilitating birth and breastfeeding. This information has been available for many years. However, recently, over the last probably 10, 15 years, there is an increased awareness of the role of oxytocin in various behavior. There is evidence supporting its role in social recognition and enhancing peer recognition. There is also information and evidence supporting its role in pair bonding and anxiety, also in trust, love, and orgasm, and as well as in maternal and paternal behaviors. Now, when you give oxytocin to individuals who are typically developing, they don't have any psychiatric disorder or neuropsychiatric disorder, it improves emotion recognition and enhance face processing. So that's why it's no-brainer to think about using this peptide, neuropeptide, and the treatment of autism. So let's review a little bit the evidence that we have. So there are several trials that's been conducted over the last several years showing that oxytocin might be helpful in the treatment of individuals with autism. In this first study, they looked at social cognition and they didn't find significant improvement. In the second study, in children, they didn't notice any improvement in emotion regulation. And the last one, that also did not find improvement in social responsiveness scale and the clinical global impression scale. So it was a little bit disappointing. And we were wondering how come all these results are negative in light of the clear evidence that this role play in social communication. So we conducted our own study and we gave oxytocin to individuals with autism, kids with autism between the age of 6 and 12. And the primary outcome measure was the social responsiveness scale. Overall, the oxytocin was very well tolerated. Interestingly, when we looked at the effectiveness of oxytocin and compared the effectiveness or the efficacy in the control group compared to the active group, we did not see a difference between the two groups, which is consistent with some of the findings that other people have reported. However, when we controlled for baseline level of oxytocin, we noticed that there is a significant difference in the group who had low oxytocin blood level at baseline, and that's the group who improved significantly. And that's how the study became significant. So that's telling us that we have to identify our sample very carefully. And because autism is very heterogeneous, we have to take in consideration the individual variation while doing our analysis. So we were very excited with the study. However, recently, there was a larger study that was conducted by Lynn Sikic and in 5 different US sites. And it's a 24-week randomized control trial. And it was followed by another 24 weeks open label study. And 277 individual, kids and adolescents participated in the study, which is a very, very good and well-designed study. And the target was using 40 international units. The adverse events were minimal, but they were seen with restlessness, increased appetite, and sedation. Some benefits were noticed with fewer infection and less enuresis. However, the major disappointment is, unfortunately, the active group did not separate from the placebo. So based on this study, oxytocin doesn't look to be effective in the treatment of the core features of autism and in the situation social communication deficits. So it's definitely a disappointment because we were hoping that they will replicate our findings, and they did do the analysis while controlling for baseline level of oxytocin, and they did not replicate our study. So that's why, and you will hear me say that over and over again, is that replication of the studies is very important. At the same time, as we were working on oxytocin, we wanted to look at its brother or sister, which is vasopressin or arginine vasopressin. So these are nanopeptides, which they have 9 amino acids, and there is a difference of 1 amino acid between the two, and their work, their function very similarly. With vasopressin, maybe more relevant for male, and in this case, in animal study, found it to be a little bit more relevant to male rodent. And when you block vasopressin, there is an impairment in social functioning, even though there might be a normal oxytocin functioning in mice, rats, and voles. So what do we know about vasopressin? Vasopressin, in typically developing individual, it enhances memory for happy and angry social information. It enhances identification of social words, and it enhances cooperative behavior. Now, how about information or studies in different pathologies? So there was one study in post-stroke aphasia that showed that vasopressin enhances speech and word formation, and another one in individuals with central diabetes insipidus, they found that there is an improvement in short and long-term memory. So in light of the close relationship of vasopressin and to oxytocin and its role in social cognition, we decided to do a small randomized controlled trial. It was a 4-week trial looking at kids between the age of 6 to 12 years and to see whether vasopressin is effective. This paper is right now published. And what we found that there is a clear benefits on social communication and overall improvement observed on parent measure, but also on clinical rating. And if you can see here, this is the placebo group, and this is the vasopressin group. There is a significant difference between the two groups, between baseline and the end of the study. And here on the clinical global impression, the vasopressin group did much better compared to the placebo group. What's more important in this study, the fact that these differences became more significant when we control for baseline level of vasopressin. So again, it's kind of the same story that autism is very heterogeneous, and we have to identify the subgroup that will respond the most to a specific intervention, because it's very naive to think that one intervention, behavioral or medical, is going to treat all individuals with autism. That's why it's important to focus on subgroups. So based on the study that small study that we published, we wanted to do a large replication study, and currently we are doing the study. We want to recruit 100 participants. Now we want to extend a little bit the duration of the study from 4 weeks to 8 weeks. We want to extend also the age range. So now we're studying kids between the age of 6 to 17. And we're including some biologic measures such as resting state EEGs and eye tracking. And if people are interested, this is the phone number to call. And the study is currently open. And I will show you the phone number later on as well. So this is very exciting. And if we are able to replicate our findings, that will probably be the first study showing effectiveness of a biologic compound in the treatment of core features of autism, and in this situation, social communication deficits. However, the story got a little bit more complicated. Vasopressin is an agonist at the vasopressin receptor. So that's our hypothesis, that stimulating that pathway will help with modulating and improving social communication deficits. However, Roche had a different compound. It's called balovaptan. Maybe some of you might have heard of it. It's an antagonist, which it does completely the opposite thing that vasopressin does. And they published a study showing that balovaptan, which is an antagonist to vasopressin receptor, might be effective in the treatment of social communication as measured by the Vineland. Now, the study that they've conducted, their primary outcome measure did not separate from the placebo, and it was the social responsiveness scale. That's why they started looking at their secondary outcome measure, and they found that the Vineland, social communication, and the composite separated from the placebo. The active group separated from the placebo. Unfortunately, they attempted to replicate their findings, and they recently announced the stoppage of their trial because their study was failed to be positive, and the active group did not separate from the placebo. So right now, using vasopressin as an agonist seems to be a promising agent for the treatment of social communication. Let's move now to a different system, the glutamatergic system. So to explain a little bit about glutamatergic system. So in the brain, in the neurons, there are two systems. One is the glutamatergic, and the other one is the GABAergic. The glutamatergic system is the one, it's the accelerator. Think about the gas pedal in your car. And the GABAergic system is the inhibitory system, similar to your brake pedal. And for a car to move smoothly, you need a balance between the accelerator and the inhibitors. And one of the hypotheses of autism is that there is an abnormal level of excitation and inhibition in key neural networks. And that's why there is a series of medications and compounds that try to modulate these pathways. I'm listing here some of the examples that reporting the evidence of glutamatergic abnormalities in autism. There is alterations in the glutamate receptor genes. There's a glutamic acid decarboxylase levels are very low in individuals with autism. There are elevated levels of N-methyl aspartate receptors in Rett syndrome. And there is some conflicting result with regard to glutamate levels. Here is a study that we conducted at Stanford, and we found that glutamate level, remember this is the excitatory pathway, the excitatory neurotransmitter is more elevated in individuals with autism compared to control. Independently of that, this is an optimal target, optimal pathway to target with medication and compounds. That's why we started to look at what's out there, what's available out there to target and modulate this pathway. It happens we came across of N-acetylcysteine, NAC, which is used in medical setting because it's a hepatoprotective and has oxidative properties. And it's a mucolytic agent that's used in emergency room for the treatment of paracetamol or acetaminophen or Tylenol overdose. What we know about it, that it modulates the glutamatergic system, but also it increases glutathione, that is an antioxidant. Also, it enhances neurogenesis and has anti-inflammatory properties. It's a very potent antioxidant with rapid first-pass metabolism. It goes through the intestine, there is deacetylation, and the liver will use it for GSH synthesis, glutathione synthesis. So that's why we embarked on a study about 10 years ago to see whether NAC is effective in the treatment of children with autism spectrum disorder. This is a study that was published in 2012, and the primary outcome measure was ABC irritability. ABC is the aberrant behavior checklist, which is a measure that will assess different symptom domain, and one of these symptom domain is irritability. The black line is the placebo group, and the dotted line is the NAC group, and you see significant improvement as early as week number 4, and continued improvement up to week 12. So this was our primary outcome measure. So we wanted to look what other domain could NAC help with. And we found some consistent story. And we found that NAC and acetylcysteine does help with restricted interest and repetitive behavior. And we saw that on 3 different subscales. One of them is the stereotypy subscale of the aberrant behavior checklist. You see NAC showing significant improvement compared to the control group. We saw that in the repetitive behavioral scale, the total raw score, there is a decrease over time. And on the social responsiveness scale, the autistic mannerism subscale, there is a significant improvement on that. So we got excited and we started looking at the literature. And this is the literature summarizing the studies looking at NAC in children with ASD. There are some case reports showing that it might reduce self-injurious behavior. In this case of a 16-year-old, it reduced frequency of hitting behaviors and hyperactivity. And this is our study. Also, some other reports showing that it helps with nail biting, overall symptom improvement, greater reduction of irritability, and hyperactivity. And something important about NAC is that it's overall well tolerated. We had very minimal side effects overall, some gastrointestinal side effects, including nausea, but no vomiting, some constipation. But in none of the cases in the study that we published, we observed this side effects led to stopping the medication. So that was very encouraging. And over the last few years, we've been trying to get funding to do a replication study, because it's very important, because you want to replicate this finding. And finally, we were able to get funded earlier this year to look at NAC and acetylcysteine in targeting restricted repetitive behavior in children with ASD. So we know that it might help in reduce irritability with limited side effects. In this study, we wanted to look to see whether it helps in restricted repetitive behavior. And part of the measures that we are including, in addition to behavioral measures, we are looking at MRI and EEG to help with identifying biologic targets for NAC. So the goal is to identify the primary mechanism of action of NAC in children with ASD. And as you recall, we have 2 different hypotheses. One, whether it's a glutamatergic agent, and the other one is an antioxidant. By using spectroscopy, we are hoping to be able to examine whether that is true or not. And spectroscopy is an imaging method that will allow us to assess the levels of neurometabolites in the brain. As you can see in the picture here, this is a spectra, and we measure the concentration of different metabolite in this voxel. And we're hoping to assess the level of glutamate before and after treatment, and also measure the level of glutathione before and after treatment. And this study is divided in 2 different components. The first one is a single dose administration to see if the NAC targets specific brain regions that are involved in glutamatergic transmission and in the antioxidant response system. But also there is a part 2 of the study where we provide treatment for about 12 weeks for children with autism between the age of 3 and 12. So looking here at the criteria, so we're looking for kids between the age 3 and 12 who are exhibiting at least moderate severity of RRB. They will be able to drink an acetylcysteine dissolved in water, and they will undergo brain scanning with magnetic resonance imaging and EEG. And if people are interested, there is a phone number here where you can get more information about eligibility. And we have a lot of experience working with kids with a wide range of level of functioning, from minimally verbal kids all the way to high functioning and quite able kids. Okay. Another study that I want to mention to you is a pregnenolone in autism spectrum disorder. So pregnenolone is a neurosteroid. It's a derivative of progesterone and dehydroepiandrosterone sulfate. Now, neurosteroids play a role in neuronal migration, synaptic functioning, and they are protective and they enhance myelination. And it has a potent action on GABA-A receptors. Remember, the GABA system is an inhibitory, is the brake pedal, and the glutamatergic system is the excitatory system. It's like the gas pedal. So with NAC, we modulate the glutamatergic system. With pregnenolone, we try to modulate the GABAergic system. A supplementation of pregnenolone have shown to improve cognitive and memory functioning. If you look at on the internet with regard to pregnenolone, you will see a lot of experts in Alzheimer's disease and old age recommending pregnenolone. So that gave us a hint that maybe we should use pregnenolone in ASD. However, we got more excited when we found that pregnenolone has been examined in several neuropsychiatric disorders, including schizophrenia and mood disorders such as depression and bipolar disorder. So we conducted, in the first step, a 12-week open-label study of pregnenolone in adult patients with ASD. Paper was published in 2014. 12 participants between the age of 18 and 35. And the primary outcome measure was the ABC irritability. So let me show you a little bit the result of this study. So on this figure, you see the baseline level of irritability as measured by the ABC, and we see a significant decrease over time. Now, I have to remind you that this is an open label study, which is not the most optimal way to assess the efficacy of a specific agent, but it's usually the first step to see whether an agent is beneficial. We also saw some improvement on the social withdrawal or lethargy subscale of the ABC, and we saw also improvement on sensory abnormalities. The compound was overall well tolerated with minimal adverse events. And when we look at the group, the subgroup who benefited the most, we noticed that individuals who had low levels of pregnenolone responded more than those who had normal or high level of pregnenolone. So that's why right now we're conducting a randomized controlled trial looking at pregnenolone in adolescents and young adults between the age of 14 and 25. It's a 12-week trial. And at this time, we can have this study conducted in person or completely remote. So we are recruiting from all over the United States at this time. Safety measures will be conducted at baseline at the end of the trial. And it's a double-blind phase followed by an open-label phase. So, which means that the individual who will receive the placebo in the double-blind phase will have the option of receiving the compound at the end of the double-blind phase. And this is the phone number to call if people are interested. Very good. So what kind of conclusions we can draw? First of all is, I want to caution everybody, don't get too excited. That's very important because these are small studies. And the example of Oxytocin, where we're very excited about our findings, unfortunately, our findings did not get replicated in a larger study. So that's why we have to wait. These are good leads, but we have to wait for large replication studies. Now, in terms of conclusion, there is the importance of following up on case reports, anecdotal reports, my experience or someone else's experience, and to maybe in the first step, consider open label studies, like a group of individuals that we treat them prospectively in a structured way. And it's important, especially in kids, to differentiate response to investigative agents from changes that are related to developmental improvement or because of school. So especially when you treat someone for 3 months or 6 months, if the kid is in school, there is a good chance that they may be learning something. And that could be a confounding factor in open label studies. So once we study something in an open label design, you want to do a small randomized control trial. If the small randomized control trial indicates there is a positive response, then you move to large randomized controlled trial. Lastly, and most importantly, is that if we find something here at Stanford, it's important that someone else will replicate these findings, because you don't know, maybe there's something specific about being treated at Stanford. So that's why you want to make sure that there's generalization of your findings. Second is that importance of heterogeneity and identification of biologically defined subtypes and subgroups, because it's unlikely, as I mentioned before, that one agent is going to treat all individuals with autism. The importance of using objective endpoints, if it's informant-based or parent questionnaires, they could be biased based on the individual impression. So that's why it's important to think about neuroimaging measure, about biologic measure that will complement the questionnaires. It's important to think whether we have a specific treatment or a general agent with general neuroprotective pro-growth agents. Specific treatment for depression versus something that will help the brain in general. It's possible that NAC and acetylcysteine may not be specific to autism, but it's a good agent to take or to give for anyone with neurodevelopmental disorders. So anyway, these are promising findings with several preliminary studies, but it's important to replicate these findings in large trials. And finally, I would like to end with this message is that it's very naive of us to think that one agent or one intervention is going to treat a complex disorder as autism. If you think about cancer, it's unlikely right now that cancer can be treated with only one intervention. As you might have heard or might have experienced, it's either you do surgery, and on top of surgery, you get radiation therapy and chemotherapy. And chemotherapy is not only one type. You have hormonal therapy, you have radiation therapy. So that's how we should imagine the treatment of autism, a combination of treatment. And at this time, we're studying one treatment at a time. So I think in the next 10 years or 15 years, we have to focus on combination of treatment or sequential treatment. And on that, I would like to thank you, everyone, and for your attention. But before I end and take any questions, I want to acknowledge the research team that without their help, this work could not be possible. And my key collaborator, Dr. Karen Parker, who is an Oxytocin and Vasopressin biologist, John Haggerty, who is a research scientist here at Stanford, and Dr. Lawrence Fong, one of our attendings in the clinic. And I want to acknowledge the people who are supporting us, the different agency and foundation, and definitely acknowledging the effort and commitment of participants and their families. Without them, this work would not have been possible. Thank you again, and thank you again for the invitation to talk about our work.
Thank you, Dr. Hardan, and thank you so much for sharing your hard work and your team's hard work and amazing insight to many of the probably cutting-edge treatment modalities that we can learn from. I have a few questions from our attendees, and I will go one by one.
Sure.
So the first question is, do you think transdermal N-acetylcysteine is effective?
So, to be able to believe that a transdermal method of drug delivery is effective, we want to make sure that the compound is transmitted enough so it goes through the skin and gets to the blood. So in general, my understanding is that whatever is done is put in locally stays locally. Occasionally there is an increase in the blood level, but the question whether this increase in blood level is significant enough is a question. And that's a little bit my concern with the transdermal N-acetylcysteine. So that we don't have evidence that there is a clear change in the blood levels based on its administration through percutaneous method.
Got it. And the second question is, what dose was used in the study?
Yeah, so NAC, in the study, we used a very high dose because we felt comfortable using high dosages because NAC has been used in the treatment of cancer and in cystic fibrosis. So the study that we used is 900 milligrams for the first 4 weeks, 1800 milligrams for the second 4 weeks, and 2700 for the last 4 weeks. In the new trial that we are doing right now, we are going to do a little bit more of an accelerated treatment. So we're going to get to 2700 after the first month of treatment. And as I mentioned, it was overall well tolerated.
Perfect. Excellent. The third question is, any indication that oral desmopressin could be as efficacious as intranasal vasopressin?
Yeah. So vasopressin is a peptide. So if you take vasopressin by mouth, it's going to be digested in the stomach. So desmopressin, unfortunately, targets only the receptors that are on the kidney. That's the first thing we try to look at, whether DDAVP can help with social communication deficits. And, I've prescribed DDAVP quite a bit over the years. It does help definitely for enuresis, nocturnal enuresis, but based on my clinical impression, I didn't see any improvement in social communication deficit. And the explanation is that it targets the vasopressin receptors on the kidneys, not the ones in the brain.
Excellent. And the second last question is, are there any plans to check which subtypes of autism may benefit most from these approaches, vasopressin, oxytocin, glutamatergic, or GABAergic chemicals?
Yeah. These days, unfortunately, you cannot get funded by the NIMH or any agencies if you don't have secondary plans or secondary analysis plan to look at subgroups. And actually, you have a high likelihood to get funded if you are targeting specific subgroups. And that's why our hope, for example, in the vasopressin study, is to replicate our findings that baseline level of vasopressin will predict treatment response, with the hope that in the next trial, we include only these individuals in the study and we examine how vasopressin is effective for them. This is a strategy that we are all using, not only at Stanford, but across the country and the world, to identify subgroups who potentially will respond better to specific intervention.
Excellent. And Dr. Hardan, the last question is a twofold question. First of all, the question was started with, thank you for all your work for the autism community. 2 questions.
Thank you.
What would you say are your key learnings in terms of study design, measuring primary or secondary outcomes, and appropriate scales and subscales? That's the first part of the question. The second part of the question is, what is your perspective on studying the combination of medications that target both GABA receptors, pregnenolone, or GABA antibody receptors like bumetanide?
Sorry, I didn't catch the second drug.
Okay, bumetanide.
Bumetanide, okay, very good. So the first question is a very complicated and a good question. So after being in the field for 20 plus years doing clinical trials, I realized that the scale that we have available are not as good as we would like them to be. I've been part of studies where we had over 1,000 of participants. We were recently part of a study looking at memantine, which is an NMDA receptor. It's an Alzheimer drug and also glutamatergic modulator for the treatment of ASD. We had 1,000 kids in that study, and we didn't see a response on average in the study. However, I treated individuals by myself, and I've noticed that some of them did improve. When you put them together in the study, there was no improvement. This is probably was related to the poor psychometric property of the outcome measures that we were using. So right now, at this time, we are working on 2 scales to help fine-tune the different measures that we are using and to make measures available that will target social communication deficits and restricted repetitive behavior. The first one is called the Stanford Social Dimension Scales, and it splits the social domains in 4 or 5 different 5 different domains. So you can target one domain or the other based on the on your hypothesis, because it's unlikely that they're going to have an agent that's going to treat all social communication deficits, from motivation to social expression to social reception, the theory of mind. So that's why splitting it is key to allow us to identify specific domain that will improve with a specific intervention. And we're doing the same for restricted repetitive behaviors. In combination of these scales, what's important to do is to include biologic measures or automated measures, such as recording of vocal interactions or recording eye contact throughout the study. So that's regarding to the first question. Regard to the second question, combination of glutamatergic and GABAergic medication, or even 2 from the same type, and from either 2 glutamatergic or 2 GABAergic, similar to bumetanide. The problem at this time is that for me to feel comfortable combining 2 agents, I want to be confident that each one of them is effective by itself. And at this time, we don't have the science yet. I think there have been some encouraging results with regard to bumetanide. We're waiting for our work to be able to replicate our findings in the pregnenolone. If both of these agents are found to be effective separately, then it will be reasonable to combine them. But to use both of them where both of them are not effective is going to muddy the water, and we wouldn't know what exactly is helping. And it's going to be a little bit harder to do the studies.